academy is actually very, very good, I think.
It's pending since long time, doctor.
देखते हैं.
Yeah, you visited. आप एक ही बार आके गए डॉक्टर साहब.
नहीं, आप तो कभी भी आ सकते हैं. केवल एक ही शर्त है, बीबी को बुलाओ और रात का खाना दमन में कराओ. मोदी के घर में ना करेंगे.
बराबर. तुमचे चिरंजीव
मोदी को गाली देना ठीक नहीं है. गांधी जी को गाली देना चाहिए. गांधी के घर में ना करेंगे.
तुमचे चिरंजीव कुठे आहे आता?
My older son is now in Stanford doing PhD.
Oh yes, oh that's great.
And the younger one is in medical school in Gwalior.
Gwalior.
Oh, Khandani College hai. My father in 52, my mother in 57, my admission in 79, my wife's admission in 83, and my son has been admitted there in 2018. तो हम तो उसको Khandani College कहते हैं. By the way, Satish, on a different note, there are two setups starting units in Gwalior.
Okay. Oh, that's fantastic.
There's a Shitla Sai unit, and I'm trying my level best with my contacts here to get something going in the medical school in Gwalior.
That's great. That's great.
मैं वहीं पैदा हुआ हूँ. मेरे पिताजी ने जिंदगी गुजार दी वहाँ पे. He's still known.
Yeah. Of course.
40 years after he left Gwalior, he's still known. तो वहाँ पे कुछ एक आध सर्जरी वजरी हो. तो ये तो academic हो जाए. उसके बाद ये इनसे बात करते हैं.
Yeah, we are always there with you, doctor, in Gwalior too.
चलिए. Good.
We have a representative.
I see a whole lot of people here.
Yes.
I am scared now. Many of them might,
So we've actually managed to register over 240 cardiac OT individuals. So
the last time I was in the academy, I had a lady who used to work with Suresh Rao.
Yeah.
And Suresh and me went back to way back in 92 when I just finished MCH and I was waiting to go to US. And Suresh was working with Kemcherian. So, ab ye to almost 28 years old. But that lady was Suresh's chief nurse. And she came back after the meeting and all and said, "मैं Dr. Suresh Rao के साथ हूँ." मैंने कहा भाई मेरे regards इसको दे देना सुरेश को. So I don't know how many of these people are there with people I have perhaps trained with, worked with, or maybe assisted or junior. I really don't know. I would be very interested in knowing where all some of them are from.
Right.
I don't know. I mean, after all, I'm 30 years old from training, so I really don't.
Good evening, Dr. Saib. Krishnan this side.
Good evening. कब शुरू करने
After
वाले?
a very long time. Yeah, I think we're on time.
Okay, then let's go.
Dhwani?
Yes. So I'll begin with the program and then we can just have the conversations post the presentation discussions.
Yeah.
Right.
Dhwani, we are live on YouTube now.
Yeah, perfect.
Good to
Okay, thank you. Yeah. So very, very good evening to one and all. I am Dhwani Purohit, and we at Merrill Endosurgery are delighted to host this two-day interactive forum called the Operation Theatre Nurses Convention virtually in these times when hosting meetings at a fixed venue is usually avoidable. At Merrill, we strive to create and develop products through innovative thinking, cutting-edge technologies, and collaboration with medical professionals with an aim to identify clinical needs and translate them into market-leading solutions. Merrill Endosurgery is a one-stop solution for surgeons, providing an extensive portfolio of products which comprise of absorbable and non-absorbable surgical sutures, absorbable hemostats, tissue sealants, energy devices, mechanical closure devices, hernia repair, and even intrauterine hormonal devices. Merrill Endosurgery products are used in more than 100 countries, and we have a rich pipeline to offer in the coming years. Before we go ahead, I have a short video for you. Can we have the video, please?
Few years ago, we came up with a dream to give it our best to the field of surgery. We asked around a lot what the doctors need and came up with products that are renowned globally. The quality is what we give day and night. That is why we make everything under our sight. Now we touch hearts, quite literally. It's affordable, so leaves behind nobody. There's more to life There's more to life. At Maryland Surgery, there's more to life. Sutures, staplers, we've got it all. Any kind of surgery, we've covered it all. First in the nation, we stand so tall. An Indian establishment to serve you all. Academy to create a future bright. Expert faculty that helps us reach new heights. State-of-art facilities. We're partners in practice and not providers only. There's more to life. There's more to life. At Maryland Surgery, there's more to life. There's more to life.
Great. Thank you for watching. And without much ado, I will now introduce our faculty mentor and speaker for today's program, Dr. Vivek Kanhare. Dr. Vivek Kanhare is a consultant cardiac surgeon based out of Bhopal and is currently heading a group private practice there. He completed his cardiac surgery training at CMC Hospital, Vellore. In his former years as a practicing surgeon, Dr. Kanhare was associated with SGPGI Lucknow and BMHRC Bhopal. He brings to the team a wealth of surgical experience along with a zeal and desire to serve the people wherever he goes. We are glad to have Dr. Kanhare with us today, whose enthusiasm and insights will leave you eager for more. And about the agenda, we will be covering two topics. Number one is the common emergency in cardiac surgery and the nurse's role in handling them. And the second one being nurse as a manager. If there are any questions during the course of the discussion, they can be entered into the chat box of the meeting window. The participants' audio will be kept muted throughout the session. In case there is any other query, also you all can type it in the chat box. Once again, we welcome you, Dr. Kanhare. Over to you.
Dhwani, good afternoon, rather.
Good
Can we have the slides up?
I will do that. So one second.
Yeah. And I'll just, guide you through and every time say next. Apologize for
Definitely.
that. But
No
I think
problem,
we
sir.
can go ahead with that. Sure.
I will just do that.
Right. While I wait for the slides to come up, I must thank Meryl. I think it was about 3 or 4 years ago that I did interact with 100 odd nurses, believe me. They managed to get about 100 nurses there in the Meryl Academy. It was a fantastic place. Imagine getting salads in the boondocks in Gujarat. But nevertheless, the language I shall use is English. I'm very comfortable with English, Hindi, and Marathi. I am open to all sorts of questions. And I, despite all my fragile ego as a heart surgeon, value the nurse's contribution to heart surgery very much. Can we go to the next one, please?
Sure.
Next, please. Yeah. Next again. We will be discussing very common emergencies in heart surgery and then a nurse's role in as a manager in this. Next one, please. Next one, please. See, we are seeing more and more standardizing of care. Across the country, the government has pushed through or rolled out Ayushman, which I think is a precursor for universal health insurance. For people who have not worked in or seen universal health insurance, say in UK or Canada, Australia or New Zealand, this is patient does not need any money. Usko koi paisa nahi chahiye. He walks in with unstable angina, gets treated and goes home. But for this, hospitals have to be accredited. So we will need more and more NABH, more and more NAACC. But you know what? The heart surgeons are on the forefront of all this. If you ever in your pastime get or Google somebody called Dr. Atul Gawande, who incidentally is going to be on Biden's task force on health, Gawande has written a very good article, a very good book called The Surgical Checklist. But believe me, the surgeons, the heart surgeons were the first people to adopt a checklist. In the entire surgical specialty armamentarium, the heart surgeons were the first guys to adopt checklist. Next one, please, Dhwani. Next, please. I put 3 slides up. I put to show you that this is a man I admire very much. When I'm finished with heart surgery, I like to go and play tennis. And I admire Roger Federer and Peter Sampras a lot. But let me tell you that heart surgeons are not Roger Federer's or Pete Sampras. Next slide, please. If anything, we are this. This is the photograph of the World Cup winning Indian team. This is who we are, teamwork. Next slide, please. And this is what we would like you to be, the operating room nurses. This is a football player I have admired for all my life. Franz Beckenbauer, who played for Bayern Munich, who played for die Mannschaft, that is the name for the German football team. And he invented the term called libero or sweeper in football, somebody who carries the entire team with him to glory. Beckenbauer is the only one of the few 3 people who has won the World Cup in football as a player and as a manager. That is how important you nurses are to us. Next, please, Dhwani. So you are the key players of the team. That is why I love talking to you. I love talking to you 4 years ago. Let me tell you a small story. I was an MS student, and we had a colleague who scrubbed with the head of the department, who incidentally tried correcting the scrub nurse all the time. Till finally the chief surgeon, who was the head of the department, incidentally my father, held his hand and told him, look, I'm going to shift to Hindi. Tum to yahan 3 saal ho. You are here for 3 years, you will go away. This lady has been with me for 10 years and more. She knows more about my operating style than you will ever know. So don't teach her. So that's how important an operating room nurse is to us. Dudley Johnson, the pioneer heart surgeon who died 2 years ago, used to visit India every time and would actually not bring his wife with him, but would bring the chief operating room nurse. This is from 50 years ago when he used to operate and demonstrate to Indian surgeons what coronary bypass was. Next slide, please. So unlike Abhimanyu, na hum na tum, nobody has learned this trick in the mother's womb. Communication is critical. You may be scared of this egomaniac who's a heart surgeon, but familiarize yourself. Talk to the surgeon. If your surgeon is not talking to you day before the surgery, there's something wrong with the surgeon, not with you. Talk to him day before the surgery. Find out what the surgery is, what the surgeon is. Is he going to do something new? And you will not have any emergencies or any accidents, mind you. Next slide, please. So what are the common emergencies you can get in cardiac surgery? First and foremost, re-exploration. Imagine you take a vein or you take a mammary, you take both mammaries, you take a radial. How many branches are there? How many can you see? Sometimes the anesthesiologist has reduced the blood pressure. The branch is not bleeding. When the patient is hemodynamically optimized, that branch may bleed. So the first and foremost emergency in any cardiac surgery is re-exploration. Any heart surgeon who says he has never seen re-exploration is 2 things. Either he's lying or he's God. So my common general protocol is to always have a re-exploration tray in the ICU with basic instruments. Maybe you don't need the fine instruments, but you need something which can cut wires. You need a Morse retractor which can retract and see where he's bleeding. Bleeding kills, mind you. Next slide, please. So check, recheck after every case. There is no harm in the chief operating room nurse walking to the ICU and asking, how much is the drainage? Are my surgeons worried? Are my surgeons happy? Has my surgeon gone home? If you are running a long list where you do 4 or 5 cases a day, it's always a good policy. Before you go for the day, before you put up the emergency list, visit the ICU, find out what's happening. Find out if anybody is bleeding. Find out if anybody needs to come back to the operating room. Next slide, please. So anticipation of a problem is solving a third of the problem. You anticipate a problem, you've already solved a third of the problem. Again, make it a rule to roughly know what is the list for the next day. You have a surgeon who does your usual coronary bypass every day, but hey, the next day he's got a minimally invasive mitral valve. Or maybe he's got a mitral valve and coronary combo. So then you have to go back and ask yourself, do I have the hardware for minimally invasive? Are all the logistics looked after? Do I need to talk to any industry person? And who is the scrub nurse who's assigned to do this case? As OT in charge, you may not be the person doing the case. I have always shared with nurses, I have not gotten this presentation, but I've always shared with nurses what is commonly used in the West called a preference card. How will a surgeon approach an operation? And it's never bad to ask the surgeon, kya karoge? No, cardiac surgery is not like Columbus setting off westwards from Portugal or Spain to discover the westward coast to India. It's all been documented, it's all been regulated, and there are standard operating protocols for every procedure in cardiac surgery. So talk to the surgeon. Don't feel that you're not part of the team. Let me remind you, I showed you that you are the Franz Beckenbauer, the Kaiser of the team. You are the person who are going to carry the team, the operation. Just the fact that you do not talk to the patient or you do not see the patient's relatives does not take away the credit from you. Next slide, please. So you have got a patient who's undergoing a coronary bypass. Now, numerous studies, and I have not got the journals here to quote you, the most critical time for a patient undergoing a coronary bypass is from the time the patient leaves the room, sedated and thus quiet, before the time actual grafting begins. Actually, studies do not show before the actual grafting. The studies actually relate to the time when you actually get on pump. But these days, all of us are doing more and more off-pump surgeries. So from the time the patient leaves his bed to the time the patient actually starts having grafts, this is when an evolving MI may take place. This is when a disaster is waiting to happen. This is when the patient will behave badly afterwards. If you have a left main coronary or a left main coronary equivalent disease in the operating room, there are set protocols for handling. My protocol in the operating room, if you have a left main coronary or a left main coronary equivalent, is for one assistant surgeon, one scrub nurse, and the entire trolley to be ready. Any ST elevation, any problem during anesthesia, fall in blood pressure, and we are there. Next, please. Next, please. So, again, you have a sick patient. Maybe you have, I will talk about this tomorrow as well. Do you have a crash? Do you have a hypertensive patient? Do you have a disaster or a very poor LV coming in? Do you anticipate any kind of assist during surgery? By assist, I mean, most commonly, I do not know how many people have seen a ECMO. We use a ECMO and a IABP. We do not use a VAG. But how many people have, I mean, most of them have seen a IABP assist during surgery. Now, an IABP assist will require electrodes, guide wire. Have you liaised with the perfusion? Is there a femoral cannula in wherein you can just, quickly thread the guide wire and thread the balloon on it? Are you familiar with the balloon? Is the perfusionist familiar with the balloon? Is the balloon pump machine in the operating room? These are all things which will help you tide over an emergent, crashing, ischemic coronary patient. Next slide, please. Be prepared for severe aortic stenosis patients. If you have a patient in whom you are doing a valve surgery with very severe aortic stenosis, well, aortic valve doesn't open. Khulta nahi hai. It's fixed. It's rigid. So the cardiac output is now fixed. Because the amount of blood which can leave the heart is determined not by the heart contraction or by the afterload. It is determined by the effective orifice area of this aortic stenotic valve. And believe me, if the patient suddenly dilates during induction of anesthesia, you have a massive problem. These are patients with fixed output situation. So are you ready for it? You have a patient with very tight mitral stenosis and atrial fibrillation coming into you for operation. And now this fellow suddenly, from a controlled ventricular rate, his rate goes to 160. There is no forward flow. Suddenly the pressure starts showing 50 or 60 on the operating room monitors. So a very tight MS also can behave as a fixed output situation. So do you have a basic instruments? Do you have a basic suture tray ready there for rapid establishment of cardiopulmonary bypass? Because once you are on bypass, these patients are going to, offload. These patients are going to suddenly relax and reduce the stress on everybody. Are you talking to the perfusionist? Are you aware of the situation? And this can, actually affect you. Next slide, please. Next slide, please. Right. This was not on the agenda, but remember, there are units which do congenital surgery. About 1/3 of our practice is congenital surgery. What do you do with a spelling patient? This patient has suddenly developed obstruction of his RV outflow tract. There is no oxygenation. There is no saturation. He has intense bradycardia. Next to bradycardia would be hypotension, and you might actually lose these patients. So are you prepared? Are you ready? Has the surgeon talked to you that, look, we may suddenly switch to shunt? And if you are switching to a sudden shunt, do you have the appropriate grafts which are ready? Do you have the appropriate sutures? Mind you, all these emergencies in heart surgery can be taken care if you are prepared, if you are thinking about it. You are doing a patent ductus or a coarctation. These cases I do about, and they scare me. PDA or a coarct scares me more than anything, any baby. PDA or a coarct is a very difficult operation because you do not have the option of falling back on cardiopulmonary bypass to let you go. You do not have the option of putting the patient on pump through a left thoracotomy. Are you prepared? Are you prepared with the appropriate tapes, appropriate clamps, appropriate sutures? Coarctation sometimes requires surgeons like me ask for a PDS, which is an absorbable suture, which is not freely available. So are you available? Are you ready with those PDS sutures? Talk to the surgeon. Talk to them. It will make your life so much more easy. Avoid all these emergent situations during cardiac surgery. Next one, please. More and more of our patients come back for redo surgery. Cardiac surgeons are a funny lot. We do not fix the surgery in the first time. We do a mitral valve repair. We anticipate that 15-20 saal baad wapas aayega for replacement or a re-repair. The problem is redo surgery, we have violated the pericardium. Howsoever Gore-Tex patch you may use, howsoever pericardium approximation you may use, under the sternum lies the right ventricle. And take it from a surgeon who's been doing redos also, except the left ventricle and left atrium, I have entered every structure. I have injured the innominate vein, I've injured the right atrium, I've injured the aorta, I've injured the right ventricle. So iatrogenic trauma is the commonest problem in a redo surgery. Be prepared for that. Is your surgeon going to heparinize before he starts splitting the sternum? Then again, the first and foremost in redo surgery, forgive me for missing that, is do you have an oscillating saw? Most surgeons use an oscillating saw for a redo surgery. Are your patches in place? Is he going to remove the wires from the previous sternotomy, or is he not removing the wires from the previous sternotomy? Will the patient need an alternative cannulation. Nurses amongst you who are practicing in pediatric unit, you cannot cannulate the femoral in small children. Some surgeons cannulate the iliacs. Is the patient hypernized before surgery? Are you using suckers to return the blood back? Does the surgeon want percutaneous groin access? I'm going to come to the next slide. Many of you may have seen a minimally invasive procedure in which you do a Seldinger technique to introduce percutaneous cannula. So does the surgeon want percutaneous groin access? Is everybody aware of what to do? What to do if I open the right ventricle? See, these are emergencies. No amount of yelling and screaming from me is going to help. So is the nurse, the assistant, the surgeon, the perfusionist, the anesthetist, 5 key people aware of what is going to be done when we are faced with a redo? Are we aware that patches are there? Because if the patient suddenly fibrillates, mind you, in a redo sternotomy, if you've not removed wires and you're using cautery and the patient has severe RBH and the backside of the old sternal wires is touching the right ventricle, the patient may fibrillate. Heart to khula hi nahi hai. How are you going to put on an internal defibrillator? So have you liaised with the person who's selling you defibrillators? Do you have a defibrillation patches on board? Are these defibrillator patches attached to the axillae, wide of where you have draped? All these things will avoid future difficulties, yelling, screaming, and in the end, a disastrous result. Next slide, please. So more and more people do a minimally invasive cardiac surgery. I, for one, do not do a lot of minimally invasive coronary bypass, but I do a lot of minimally invasive ASDs, mitral valves, and aortic valves. So have you seen an MICS? If you've not seen a minimally invasive approach, and your surgeon wants to do a minimally invasive approach, ask him. Ask him as a lead nurse to send you to a place where they do an MICS. Get comfortable, discuss with the surgeon, know the plan about the cannulation, have appropriate long sutures. Mind you, I've been yelling hoarse and screaming for a 90-centimeter suture in 7-0. Nobody has provided me with that. So talk about the 90-centimeter longer sutures, because you're going to be operating in depth. There are going to be different instruments. There are going to be different cannulae. You're going to flood the entire operating room field with carbon dioxide, primarily because de-airing is never effective. And you do not want to have a patient with a small incision not wake up because you did not get rid of his air. So have you talked to the laparoscopic surgeons in the operating room? Have you got a carbon dioxide cylinder? Are you insufflating carbon dioxide in the operating field? And lastly, but not least, what happens if you're not able to do a minimally invasive cardiac surgery? Are you draped so that suddenly you can close the small right thoracotomy and convert to a standard approach? Mind you, that is when things are hitting the, the SHIT is hitting the fan, things are going south, surgeon is not comfortable, he's not been able to get this minimally invasive surgery. He promised this young lady so that she can get married. I will do a small incision mitral valve and you'll be very happy getting married a year later. But he's not able to do it. And now he wants to convert to a sternotomy. The tension is on his head. Are you draped? Do you have the stuff somewhere very close by so that you can quickly switch to conventional standard sternotomy and cardiopulmonary bypass and a mitral valve replacement with which all of us are comfortable. All of us are comfortable. So be prepared for all these things. And that is what will avoid all these emergencies and catastrophes. Next slide, please. Next slide. Okay, I think I have scared you enough. I'm going to scare you more tomorrow when I actually discuss all these difficult situations. But right now, I've been at the start of my presentation, I showed you those slides. I pointed out the role that you are very important to me as a manager. I have a young man who has been working with me for 13 years as a nurse in charge. I do not really do not know what sutures are available in the hospital, what valves are available in the hospital. He walks up in the morning and tells me, sir, ye sab hai. So he is a manager excellent, a manager beyond ordinary. And believe me, you all nurses, I see you, the chief operating room nurse, I see you in your role as a manager. Jokingly, I tell my co-workers that there are two people who run my life. My wife till 9 o'clock, and from 9 to 4, my operating room nurse, who's a manager who runs my life. Beyond these two people, I do not have anybody else who runs. I don't run my life. Next slide, please. So you are a coordinator, you are a facilitator, you are a mentor. हर आदमी सीख के नहीं आता है. Not every nurse who steps into the cardiac operating room learns. You have to teach them. You are the mentor. You introduce new nurses to the surgeons. You introduce new surgeons. You introduce other team members. I actually share the dishonor of actually making every nurse who has worked with me cry. But that is not something I hold as a badge of honor. But the nurse should be comfortable with you. The general rule in my unit, we have 3 surgeons and we work with a lot of nurses. The general rule in my unit is that the newest nurse works with me. I'm the senior most surgeon. She works with me. If she can work with me, she can work with anybody. Next slide, please. So you are the team leader. You are responsible for the health. You are responsible for the optimal working situation in the entire team. By team, I mean the nurses, scrub nurse, assistant nurse, junior technicians. Identify all the hazards which can potentially happen in the operating room. Take appropriate preventive measures. A very small thing is universal precautions, breaks, slippage, fall. As in charge, you are also responsible for managing inventory. You are responsible for managing supplies. Be sure about what the choice of your surgeon's valvular prosthesis is. Do you run an enterprise resource program? I mean, this may sound very funny, but there are ERPs which are commonly run by SAP, which is a program out of Germany, or an Oracle program. I will come to this later. If yes, then do you revisit your ERP levels? I can't. Next slide, please. So, are you a store manager? Do you handle medicines? Are you in charge of narcotics? Are you responsible for procurement? We will take up all these things one by one. See, most cardiac operating room nurses do not actually handle medicines. They are also not in charge of narcotics. I am not sure. I mean, at the start of the program, I saw there were 53 of you. I am not sure how many of you come from different units where you are responsible, partly say for the anesthesia part of it, partly say for the perfusion part of it. But if you're responsible for the anesthesia part of it, then mind you, you're handling medicines, and more importantly, you are handling narcotics. Next slide, please. So be aware of medicines. If you're handling medicines which may be needed, be aware of the fact that the surgeon might require inotropes on the operating room table. There are some surgeons, when the patient is not doing well, would like to inject intra-aortic adrenaline, intra-aortic, or if you're on pump and they want to raise perfusion pressure, they might want to inject intra-aortic phenylephrine. But the most common medicines which may be needed on the operating table are, after harvesting a mammary, a papaverine. Papaverine to bathe the mammary in so that the mammary dilates, or in certain cases, antibiotics. Replacing a valve, many surgeons, when they wet their hands, when tying sutures, will have a solution which has some antibiotic in it. They will also, perhaps, if they're treating, would like to infiltrate antibiotic along it. If you ever look after narcotics. Please be careful. Please be careful of the narcotic rules. Please have a protocol in place. Please have a narcotic cupboard in place. And your surgeon is not going to help you in this. Your surgeon will be the first person to say, "Mujhe kuch malum nahi hai, I don't know anything." So liaise with the anesthesiologist. Have a clear protocol. All of these drugs, fentanyl, pentazocine, morphine, they're all addictive. And then if you're using drugs and you're in charge of inhalational anesthetic drugs, how are you scavenging the inhalational anesthetic drugs? Talk to your anesthesiologist. Is it closed circuit? Are you scavenging it outside? Are you giving it on the pump? Remember, a sizable fraction of our operating room colleagues are females. And there is a direct correlation of anesthesia gases and fertility amongst females. So at the cost of being cited for sexual harassment, I generally make it a rule to make sure that the females are not exposed to these kind of inhalational anesthesia drugs. Next slide, please. If you are in charge of procurement, my nurses are in charge of procurement. I never decide what sutures are going to come. I just tell them at the start of a financial year, ye yahan se le lo, ye yahan se le lo, ye yahan se le lo. Finished. So if you are in charge of procurement, beware of surgeon's preference. There might be two surgeons in the team, one of them using atoproline, one of them using seminoproline. One of them using seminoproline with a 13 mm needle, one of them using seminoproline with a 9 mm needle. So be in charge of all this. Be aware of this. See, you are the manager. You have to tell them. Aapko yahi milega. Be aware of a single use or a repeat use policy. Now, if I am quoted ever in somewhere else, I will blankly deny ki repeat use hota hai. But the fact is, most of us reuse cannulae, reuse a lot of stuff. So be aware of the policy. Make sure it is not the junior most nurse who sends these things for re-sterilization or reuse. Be aware of it. Make sure of these things. Be aware, does your hospital use an enterprise resource planning? An enterprise resource planning is basically where the hospital has a central store. Uska ek minimum level aane pe automatically the order is generated and sent to the vendor. The vendor automatically supplies. There is a sub-store. The sub-store is what, as an operating room nurse, you are going to be in charge. These sub-store values may go up and down. If you're doing 2 cases, your reorder levels, thresholds might be higher. Suddenly your hospital takes off and you start doing 5 cases. Then your reorder levels have to go down. So be aware of all this protocol. Don't hit the computer. For God's sake, all of us are on this computer thanks to COVID for this virtual meeting. Don't hate it. It's very easy to operate. So don't hate it. Be aware of your ERP. Even liaise with the, hospital stores and supplies. Next slide, please. Be aware of how the hospital handles tissues. Be aware of what happens to the culture protocols. You are at one stage or the other going to get a patient with prosthetic valve endocarditis or a native valve endocarditis. So be aware of this. Be aware of your histopathology protocols. You are again a manager. The last thing you want to do is send a valve for culture in formalin or send a histopathology in saline. But at the same time, I am not sure how many of the surgeons are doing thoracic work in your unit, but if you're doing thoracic work and you're doing something called a mediastinoscopy and you're grading lymphomas, be sure that these lymphomas, these lymph node specimens generally are not sent in formalin. They are sent in saline because they are tissue typing and all is going on. If you're working in large academic institutes, I really do not know. I have no flavor of the audience in front of me, but if you're working in large academic institutes where some of these tissues might be involved in ongoing trials. When I was training, we had a tissue trial going on with excised right atrial appendage and BNP. Levels of BNP in various degrees of depending on NYHE class. So when we excised the right atrial appendage for cannulating in cases of valves, we didn't throw them. The nurse took them and gave it to the guy who was conducting this study. So be aware. If you're in a teaching program, be aware of ongoing trials, if there are. There will be enough markers and there'll be enough warnings for a nurse manager in place to handle these tissues appropriately. Next slide. These days, I don't know how we are all operating. All my patients are getting COVID screened. I suspect, like HIV and hepatitis, COVID screening will become the future way to go. As a nurse manager, you are responsible not only for yourself, but all other junior nurses who are working under you. So make sure that they take what is called universal blood bodily fluid precautions. To my horror, my junior nurses do not wear eye protection, masks, and gloves. Mind you, I showed you the first slide with NABH and NAACC accreditation. One of the first and foremost rules of an NABH certified hospital is that you cannot, and I will repeat, you cannot identify or tag a seropositive patient in his file anywhere. It is strange. A hepatitis or HIV patient has more rights about his privacy than we as an operating room nurse need to know. So every patient should be presumed ye hepatitis positive hai or ye HIV positive. So adhere to universal blood bodily fluid precautions. Wear glasses, wear gloves, handle pricks. Liaise with your occupational safety officer. If there is one, large institutes generally have an occupational safety officer. Small units may not have an occupational safety officer. But there is always a protocol. Needle ghus gayi, blood nikla, you've been poked with a needle, you've lost some blood. Then there is a set of protocols. You might know the patient's serostatus. You want to get your own serostatus done. And as an operating room nurse manager, maybe you're not scrubbed. Maybe your junior nurse is scrubbed, but you need to know all these protocols. Next slide, please. So, as a manager, you have to liaise with the ICU and pre-op staff. Handshakes and checklists, very important. You are a manager, a patient comes to you for surgery. That is when you liaise with the pre-op staff. Generally, most NABH hospitals and NACC hospitals will have allergies flagged, everything flagged. But the nurse who shifts the patient talks to you, tells you कि इसको ये तकलीफ हो रही है. Before I injected him with a sedation or a pre-anesthetic minute, the patient complained, I have some chest discomfort. Now go back to the first slide where I said emergency and evolving myocardial infarction. There is a red flag. This patient had chest pain. This patient was very anxious. When you take the patient back to the ICU, there should be a similar handshake. We call it a handshake actually in surgical parlance, where you tell the ICU nurse, maybe as a manager, maybe as a junior nurse, but as a manager, you make sure that this is told. Maybe as a manager, you make sure that the patient did not have any cautery burns when he left the operating room. Aaj aapko lagta nahi hai, today you do not feel that stress. 10 years down the track, you will have patients suing you for cautery burns. So as a manager, make sure that you've told the ICU staff ki koi cautery burn nahi hai, koi electric pad se injury nahi hai. This is I am handing you with the patient. And more important, liaise with the industry. Every day industry, including the people who are sponsoring this session, are shoving newer and newer products down our throat. Who thought that one day you would be putting percutaneous aortic valves? I did not think so when I was training. Who thought that what needed 9 minutes to wash, a bioprosthetic when I was training needed 9 minutes to wash, has been reverted to a 1 minute wash these days with newer bioprosthetic valves. Who thought that you would be able to put in a Seldinger cannula to get a percutaneous bypass? I did not think so, but we are. Who thought that sheathless intra-aortic balloon pumps are going to come? So every day brings us new products. So liaise with the industry, talk to them, Talk to them about the mechanical valve they give you. Talk to them about the rotation of the mechanical valve. Talk to your surgeon to organize a CME about all this. Talk to your surgeon about newer ways of handling stuff. Talk to your surgeon about newer ways of harvesting veins. Industry is not our enemy, mind you. We would not have reached this level, and I'm not saying this because the industry is organizing this program, but scientific innovation, translational research, and industry is very, very important for future development of heart surgery as we know it. Next slide, please. So you are a de facto team captain. You are responsible. And gone are the days when you could have verbal and physical abuse during and after surgery. You could have sexual harassment during surgery. I actually belong to the intermediate generation. My seniors belong to the dinosaur generation, where surgeon was God and he could say anything to the nurse. He could abuse, gali de sakta tha, he could curse, he could sexually pass a comment and get away with it. That's not happening anymore. That's not happening anymore just because the junior most nurse has come with Dr. Kanere and she's an attractive looking female, doesn't give Dr. Kanere the license to say anything to her, less other than professional comments. Next slide, please. Next slide, please. So anecdotal tales of colorful temper tantrums and outbursts by surgeons directed at operating room nurse and times at other healthcare providers are part of history of surgery. I have not thrown an instrument now for the past God knows how many years. I dare not. Any surgeon who chooses to act out his or her frustration and nervous energy demands by abusing co-workers is actually laying himself open for a malpractice suit or a sexual harassment suit. Many of you would laugh at me, ye kya bol raha hai, kya? One of these days, all these things are going to come. And the most important part is that if you have an out of control temper tantrum and disruptive behavior, this actually may or may not affect you or your relationship with the nurses, but in the end may actually translate with a bad patient outcome. A yelling surgeon, a screaming surgeon, a surgeon who's throwing instruments is not good. If you ever have an episode like this in the operating room, walk up to the surgeon after he's cooled down. Remember, all of us are in this game to get the patient home safely. And talk to him. Kya galat hua? What went wrong? How do you think we can improve? And then gently point to him, sir, ye nahi chalega. This will not happen. You cannot curse my girls or my boys like this. And that will make you a long way as a successful manager. Next slide, please. So if I do this and nobody talks to me, then I can do it again. Yes, I may be God. I may make rules, but deep down, all of us know that I am not God. If I throw temper tantrums, then this is what we started in the start. Remember? Emergencies during cardiac surgery. So this behavior reflects that we planned for the surgery poorly, that we have poor social skills, that we are poor communicators, and it should not be tolerated. It does not, aisa nahi hai ki it only works in older surgeons. It actually starts more in younger surgeons. I have always told my junior colleagues who work with me that the senior surgeon becomes like a bargat ka ped, huge and unforgiving and bowed. So much surgical experience teaches you, actually should teach you and has taught me humility. So these temper tantrums are completely out of the control, and as a nurse manager, you have a role in stopping them. Next slide, please. On a very lighter note, I like to end my all surgical talks to nurses with this. When we were training, we were taught that there are A, B, C, D of heart surgery, and all heart surgeons, egomaniacs like me, work like that. A stands for analyzing the problem. Another A stands for accusing or blaming somebody else for causing the problem. The third A stands for acting, or C, curing the problem. And the fourth A, most important for fragile egomaniacs like me, is to announce and declare to the world that how me and me alone as a heart surgeon have saved the day. These are the kind of people you as nurse managers are dealing with day in and day out. Heart surgeons as a nature are very insecure. They want their best. They don't want any patient to die. You see, they might boast in any conference that I have 0% mortality, but deep down in their heart, they know that some patients die. So don't get scared of these people. Don't get scared of these people who run around in scrubs thinking they are God. They are not. Communicate. Draw up a plan. Have a checklist. The universal goal is of executing a well-planned surgical procedure with a successful outcome and sending the patient home, which you, unfortunately, as an operating room nurse, may never get to meet the patient or his relatives. But that should not deter us from the ultimate goal. Thank you very much. Next slide, please, Dhwani. Right. I will see you tomorrow again. I'm open to all sorts of questions. Dhwani, you can take it from here.
Yes, sir. Thank you so much. I will just scan quickly at the chat box and get back to you for any questions there are.
Right.
And if in case there are any queries or questions for Dr. Kanare, please put it in the chat box. We take them now.
Oh, there are 22. Something happens 23 now.
It's just greetings and all that, sir. There are no questions as
Okay.
yet.
Somebody said Hindi, please, sir. Hindi bola, sir. Sir, Hindi. Hindi, well, मुझे ये बताया था कि हिंदी में बात नहीं कर सकते हैं, लेकिन I am ready to, one-on-one, I am ready to do this in Hindi. I am also ready to, Merrill guys have been actually very good. Unfortunately, this COVID thing has stopped. I'm ready to do it on one-on-one, in which case I can, when I'm free out of this presentation, as I pointed out, I'm ready to take it in English, Hindi, Marathi, kunju Tamil teriyo, Tamil nalla pesa kodade. I don't know if there are any Tamilians there. Nalla pesa kodade, but well, yeah, and not in any other language. I apologize. Right? Any questions or something? No? Oh, there are some. No, there is thank you.
No.
All sorts of thank yous.
So if you would like to have an interaction, we could probably just open the audio for people and, you could just have a conversation with them.
Go ahead.
Yeah.
Everybody's audio can be open. Please introduce yourself. Ask me anything.
Good evening, sir. My myself is Rini Makwan, and I'm in Cardiac OT in SVP. Thank you, sir, for your lecture. You just explain whatever we experience in our cardiac OT. You just remind us all the environment again. Thank you, sir. And thank you for appreciating us. Thank you, sir.
I thought you would have some question.
No, sir. Right now we have no question. I just go through your lecture, and I'm thankful that you appreciate nurses, especially the lecture was on nurse. So
I was supposed to talk to nurses, and believe me,
because you know our pain that during surgery we experience so much tantrum of surgeons, but we know that they are in stress, so that they just
I can see it on a video, and I can see that you're a lady. I am very sorry to admit this, but then you know what? I have had all ladies who scrubbed with me weep on the operating room table at least once. I speak a lot, but practically I may not be the nice guy who's talking. But I hope you appreciate that we are all in this game to get the patient home. I see somebody called,
Yes, that's our only goal.
where do you
And
work?
right now I'm in SVP hospital, sir.
Where?
It is in Ahmedabad.
Oh, good. Okay.
Yes.
Ahmedabad was the last meeting.
I was in UN Mehta last 5 years. And then I
Mishra.
joined this.
Mishra,
Yes, Amit Mishra. sir.
Mishra,
I
Jignesh
worked with
Kothari.
him. Then Jignesh Kothari, sir. Then Chirag Joshi, sir.
Yes. I thought I had somebody else.
I don't know, sir.
No, I think somebody, Madhav, somebody.
Okay, sir. Thank you, sir, once again.
Thank you. Mani, are you going to have breakout rooms here or no?
So we do that tomorrow. We'll have that forum discussion tomorrow within the
Okay.
group.
Any more questions? You can.
Any more questions for sir for today?
There are again 6 chats I have not seen. Thank you. There are a lot of bunch of thank yous. No other questions.
I don't see any questions coming in. Yeah. Okay. Right. So nothing coming in.
Any questions on YouTube?
No, there are none.
Okay.
Can you send me the link on YouTube? My son who's studying to be
I will do that, sir. I mean,
and
that
my
will be
son
available.
who's studying to be a physician. He's
Right.
studying MBBS, would be amazed that his dad's on YouTube.
Surely, so
And
the link will be available. I will give it to you.
thank you.
No, not
Thank
a
you.
problem. Yeah, surely.
Also would
So-
perhaps like to have a list of all the participants on this
Definitely.
show so that we know where we have all reached. And
Surely.
and perhaps I can share tomorrow. I can give you my office email ID in case anybody is interested in mailing me personally and asking me a question.
Right. Okay, so there aren't
when
any
you
questions
check
for now.
If somebody wants to ask a question even in Hindi, because there's someone who's typing.
Yeah, I
consistently.
mean, the forum is open. So if
I
there is
I
anyone,
am very comfortable in Hindi. I have no issues with Hindi. As I pointed out, kunju Tamil pesuno, nalla Tamil pesikoda. And the only bloody sentence I can say in Malayalam, I would not want to say publicly. Other than that, definitely.
நீங்க நல்லா தமிழ் தான் பேசுறீங்க பிரச்சனையே இல்ல माझं पण तसंच आहे की तुम्हाला जेवढी तमिळ येते तेवढी मला मराठी येते.
Oh, okay. Yes, I can converse in Marathi, but not in anything beyond that. Not in Malayalam or not in Bangla.
I think it's the first day for people. Maybe they are just warming up.
yeah, so I guess we'll have a group discussion and common forum conversation tomorrow. So in
Okay.
case there is any hesitation today, I think people will be great
नहीं,
tomorrow.
शर्माने की उसमें कोई बात नहीं है. As that lady very succinctly put it, theoretically or practically, I realized that without a operating room nurse, and let me tell you the story I told you at the start related to my father. My father was a very senior thoracic surgeon, and one day one of our colleagues was trying to teach the operating room nurse, and उन्होंने उस लड़के का हाथ पकड़ लिया. बोले, don't teach that lady. She's been with me for 10 years. She's going to be with me for another 10 years. She knows more about me than you ever will. So most of the operating room nurses we have worked with, or I have worked with, and I have had the luxury of being associated with, you see, the association between a surgeon and an operating room nurse changes. When you are a resident, she actually shields you. A good operating room nurse, आपको surgeon की गुस्से से सबसे, if you are a resident, बचाएगी. But as you become more and more senior, and I am now 58 years old, 30 years post MCH, if the case has gone on long, my operating room nurse will actually stop and ask me, sir, aapko diabetes hai, aapne kuch kha liya ki nahi? So that is how the relationship is between me and my operating room nurse, and that is how it should be. We are a part of the team. So that's that. So shall we call it quits then?
Yes. So before we just close this, I will put up a video of the facility that you were talking about. We could have a physical meeting at, so that
Yes.
for the benefit of the audience, they also know what we're talking about.
And it's
give
actually,
me a brief
I will
moment.
let you know, let the audience know. I had the opportunity of doing this about 4 or 5 years ago. Nurses.
So you've been mute. Yeah.
I was dealing with 100 odd nurses, and the farthest came from Northeast India to Gujarat. And it was a fantastic academy and a fantastic experience.
In fact, Dhwani, a time check today also. How many people?
And hear you, Krishnan. You gone mute.
She muted me anyway.
No, I didn't.
Okay, fair enough. I was saying, do we have a record of how many people? Aaj kitne log South se hain? How many are from? Do we have some sense of that?
So we'll
maybe tomorrow we
get
should
to
talk
that
about it.
tomorrow. We'll do that tomorrow because this is a
It makes
live
sense.
migrating audience, so it is very difficult for me to navigate
When
that.
we
Right
were creating this program, sir, our assumptions that we will get slightly more numbers because it is virtual in nature. However, we understand that physically milna, chai pina, chuski lena, pani pina, or sunna, or gappe ladana. This is also part of that meeting. So that's one small physical element which will go amiss.
Is
We
this
understand
session being still recorded on YouTube?
Yes.
Oh my God! Otherwise, I would not say chai nahi, scotch pina.
I'll stop it right now.
I think stop it. We have done it.
Yeah.
Technical
Okay.
part.